Swelling with Danger and Silent Culprit by Dr. Thilini Hemachandra. She's a consultant rheumatologist and consultant in rheumatology and rehabilitation, District General Hospital, Ampara.
Good afternoon to all of you. Thank you very much, sir, and thank you very much, Ceylon College of Physicians, for giving me this opportunity to talk about two of the cases which we encountered in District General Hospital, Ampara. Swelling with Danger and Silent Culprit. This is the outline of my talk. My talk will be based on two case scenarios. Case 1. This is a 16-year-old female who presented with sudden onset difficulty in breathing and swallowing with drooling of saliva for 2 to 3 hours. She denied any food or drug allergy and there was no history of fever. And she's a known patient to the rheumatology department, so let's have a look at her past medical history. She was initially presented in December 2023 with inflammatory type joint pain with morning stiffness lasting for more than 1 hour. And the involved joints were bilateral wrist joints, proximal interphalangeal joints, bilateral second metacarpophalangeal joints, and third metacarpophalangeal joint right side. And there was a history of painless cervical and inguinal lymphadenopathy for the preceding 4 months, and which was investigated. The biopsy revealed reactive nodes and which resolved spontaneously. She had hair loss, but there was no oral ulcers, photosensitive rashes, or symptoms suggestive of Raynaud's phenomenon. I would present only the specific investigations done. ANA was positive, 1 in 80, and with a nuclear homogeneous pattern. dsDNA was positive, and both the complement C3, C4 were low. So the diagnosis of systemic lupus erythematosus was made. She was commenced on hydroxychloroquine, methotrexate, together with bridging therapy with prednisolone and gastroprotection and vitamin D3. As the time goes by, she had non-compliance, which she initially didn't come up with because of the nausea and vomiting for methotrexate, and which led to multiple flares in couple of occasions with skin and joint involvement and a little bit of renal involvement as well. So on 8th of August 2024, a decision was made to change methotrexate to mycophenolate mofetil, and by this time she had itchy papular erythematous rash over the photosensitive areas, mainly feet and forearms, and there were oral ulcers with joint involvement. And even though it was changed to MMF, still the patient was having the symptoms. There were 2 other admissions very close by, with one with arthritis, one with rash and arthritis, probably the same episode going on. On 29th of August, nearly 3 weeks after the initial switch, patient presented with difficulty in breathing. At emergency department, DGS Ampara, patient was found to have submandibular swelling and the swelling of the tongue, but there was no stridor and the saturation was maintaining on air, and patient was afebrile. Because of the impending respiratory compromise, patient was intubated and ventilated. Later, CECD chest, neck, and thorax was done. As you can see, the black area indicates the endotracheal tube, and you cannot differentiate a pharynx or any air space here. There is submucosal edema of the pharynx, tongue, which revealed angioedema. So at this point, the team were thinking about infection in terms of Ludwig angina, and later patient was referred to rheumatology department And our differentials were whether this is SLE-related angioedema or microfilament morphetil induced, even though it was 3 weeks after the commencement. However, the procalcitonin and blood culture came as negative, and at this point, effectively excluding possibility of infection, and also there was low complements. Patient was commenced on IV methylprednisolone 500 milligram once daily for 3 days, and on day 4, she was extubated with marked improvement of swelling. And it was decided to give IV rituximab 500 milligram weekly for 4 doses. The last rituximab dose was given on 10th of September with oral prednisolone. By that time, patient was on 25 milligram dose. And a month later, patient again presented with a painful erythematous rash on fingertips, which were non-blanching, and patient had a hair loss as well. So this vasculitic rash was treated with prednisolone up titration and azathioprine 75 milligram once daily. And currently, patient is doing well with azathioprine total dose of 100 milligram per day and with tailing off of dose of prednisolone. So the final diagnosis was SLE-induced angioedema. And as you all know, SLE is a multi-system disease which has diverse presentations. Therefore, I intend to discuss only a couple of points in the interest of time. Antinuclear antibody. This is present in 95% of SLE patients, but also positive in 5% of adult population. And it has a poor diagnostic value in the absence of clinical features of autoimmune rheumatic disease. So how about the ANA patterns? So there is this website for what we are using is ICAP, the international consensus for ANA pattern. So it has from 0 to 28 patterns. And if you click on any of these icons, you will be able to find which pattern indicate which antibody and which predict which autoimmune disease. Right. So if the ANA is not diagnostic, or then how do you diagnose? So there are classification criteria for SLE. The first being from 1971. But mind you, these are classification criteria and they are not diagnostic criteria. So always you'll have to use your clinical judgment in diagnosing systemic lupus erythematosus. So with the better understanding of the disease manifestations, here we have a better criteria so far. At 2019, EULAR ACR criteria is the one we are using at the moment, which indicate ANA titer of 1 in 80 as the entry criterion. So there are clinical domain and immunological domain, and you need at least 1 from the clinical domain, and you need to score at least 10 from this list. And these manifestation doesn't need to be present simultaneously. It can be present in other times as well. So you have to take the cumulative scoring system. So once the diagnosis is made, how do we monitor the disease, or how do we monitor the disease activity? There are a couple of disease activity tools which are not very feasible in terms of using in a busy clinic, but I would like to highlight, recently we had 2 cases where unless we screen for these symptoms, patient will not come up with, because SLE is a very diverse disease with a lot of clinical manifestations, and patient might not think a certain symptom is related to their SLE. For example, 2 patients came to our clinic during the last 2 months did not think that their fits are related to SLE. So, so these are the ones that we use and recommended by the British Society of Rheumatology, BILAC, and Selena Slidai, which is available online, and it's a useful tool mainly to screen and to see where you are in terms of treating the patient with and the disease activity. So a couple of points I would like to highlight. Please do a rheumatology referral when a patient is admitted, when a patient with SLE is admitted. And also the CRP is normal unless there is serositis or infection. And procalcitonin might be a useful tool to differentiate infection sometimes. And antiphospholipid antibodies should be tested in all lupus patients at baseline. So this is BSR recommendations again. And treatment of lupus is depend on the disease-modifying drugs depends on the specific clinical manifestations, which I will come in a little while. And there is a debate with regard to the HCQ dosing. So it is two guidelines say two different dosing. However, it is 5 milligram per kg per day dose or less than 6.5 milligram per kg per day dose. A few words about complements. As you know, so we discussed about the ANA pattern and the titer. So the other antibody that we do is anti-dsDNA titer. And Smith antibody is also specific for SLE, even though we do not do routinely. And the other thing we do is the complement levels, C3 and C4. So out of that, C3 is said to be generally higher sensitive than C4 for active, especially the lupus nephritis. And I have to highlight this point. It has a high negative predictive value to exclude active disease, especially the renal disease. Methotrexate, nausea, vomiting give rise to huge non-compliance. Please do ask from patients. You might increase the dose of methotrexate, or you might add another DMARD, thinking that you are treating inadequately, to find that patient is taking only half a dose of methotrexate just because they have nausea and vomiting. And unfortunately, we do not have the luxury of having injectable preparation of methotrexate. HCQ maculopathy monitoring, screening, again has a lot of confusion. So this is the guideline by American Academy of Ophthalmology. So you can do a baseline screening, but you don't have to wait for that screening for you to start hydroxychloroquine. Within 1 year of screening is enough, unless patient has other risk factors, of course. And after 5 years, annual screening is adequate. Again, unless there are any other risk factors. Treatment, as I said, depend on the clinical manifestations. So here they have divided into mild, moderate, severe. So what is mild SLE? Mild SLE indicate constitutional symptoms, mild arthritis, rash, and moderate indicate moderate to severe arthritis and a rash which is severe, and also serositis. Severe indicates major organ or life-threatening disease. So this is the EULAR recommendation. 2023 update is the one we are using currently. So they have two categories, for non-renal and renal. For non-renal, there are 3 categories: mild, moderate, severe. So as I previously discussed, so there are particular manifestations for under these mild, moderate, severe. So according to that, only we are treating. And as you can see, hydroxychloroquine is indicated for all the patients unless it is contraindicated for its obvious benefits, reducing flares, reduce cardiovascular morbidity, and reduce development of CNS lupus. A few words about glucocorticoid therapy. We do use glucocorticoids as a bridging therapy, but short term, when possible, withdrawn, if not used in low dose. Now, low dose is also there. There are debates. The EULA says less than 5 milligram, and BSR says less than 7.5. However, so when possible, try to take it off, if not a low dose. Now, as for disease-modifying drugs, methotrexate, azathioprine, mycophenolate, mofetil, all three of them can be used. There is no hierarchy in these DMARDs, but for joint disease, we tend to prefer methotrexate or azathioprine, but there is no hard rules on that. And there are two newer biologics, belimumab and anifrolumab. We know SLE is a B-cell driven disease, so belimumab is related to this BAF and this pathway. So, belimumab can be used for skin, joint, and as well as renal disease, but not in severe neuropsychiatric disease. And anifrolumab, again, blocking the interferon gamma, and this can be used in skin and joint disease. This is not used in lupus nephritis or severe neuropsychiatric disease. Unfortunately, none of these biologics are available to us. If I go back to my previous slide, so for the severe manifestations, either cyclophosphamide or rituximab can be used depending on the fertility wishes, because as you know, cyclophosphamide affects the fertility. And if you really have to use, there are options of storage, but then how far that is activated in Sri Lanka is in doubt. Rituximab we can use as for the refractory disease. Rituximab can be used, but for the fertility wishes, again, instead of cyclophosphamide, rituximab can be used. So this is the management of lupus nephritis. As you can see, there is no belimumab is there and anifrolumab is not there, and there are other adjunctive therapies with ACE inhibitors. Right. So this is, if I discuss a little bit about the theory about our patient. So angioedema, it could be two types, hereditary and acquired. Acquired can be, the etiologies can be lymphoproliferative disorders, lymphoma, and neoplasms, infections, and of course connective tissue disorders like SLE. So for the acquired, treatment would be steroid, cyclophosphamide, rituximab, any of these can be used, as we used in our patient very successfully. And this point I need to highlight, SLE needs to be considered as a differential when a patient presents with angioedema to prevent delay in diagnosis and initiating specific management. So these are the two case reports. So remember, angioedema can be the first presenting symptom of SLE, and recurrent angioedema also has been reported in SLE patients. Case number 2, silent culprit. This is a 63-year-old female who complained of mechanical back pain for about 3 years. There were no red flags, and the physical examination revealed mild scoliosis. So she was given NSAID and sent for physiotherapy. Somewhere down the line, somebody took a X-ray lumbosacral spine, because as you all know, we do not take X-rays for all the back pains that are presented. But I'm glad that this X-ray was taken and X-ray reporting was done. It said extensive calcification in a nuclear pulposus, suspicious of Alkaptonuria. History was revised, and to find that this lady's parents were consanguineous, and the patient remembers mother telling nappy being stained brown after passing urine and kept it out for some time. And also she revealed that she has a sister with the same symptoms. So at this point, we all sat down and actually did a little bit of reading because none of us knew what to do. So according to that, we started doing other investigations. However, the diagnostic tests could not be done because it is not done in Sri Lanka. And at the moment, we are negotiating with a team from India with regard to the genetic confirmation. So this is a rare metabolic disorder with autosomal recessive inheritance. And this is because of the deficiency of homogenesic acid oxidase enzyme. So it is the accumulation of this pigment, and then it can go and deposit in the ears, sclera, cardiac valves, and also joints. Actually, even though the disease is present at birth, the manifestations usually start after third decade. Patients commonly report mechanical joint pain, especially knee joint pain and back pain, like in our patient. And so, as you can see, the X-ray is very similar to our patient. So, and a cut section of this which is taken from internet, shows the deposition of this pigment. And the histopathology is this brownish pigment. And so again, the diagnosis, history examination for us, urine homogenesic acid can be done, but not in Sri Lanka, and the genetic testing for this particular mutation. So this is not the urine sample of our patient, but as you can see, with the prolonged exposure to air, it can get darkened. And this is a case report this study from India. This late Professor Debashish Danda was eminent rheumatologist who passed away unfortunately recently, and his spouse, Mrs. Dr. Sumita Danda, kindly agreed. But then still we are in terms of discussion because of the cost involved in sending the blood test, blood and getting down the genetic confirmation. So this is a study done in India in a gypsy population where they found this mutation and the musculoskeletal symptoms were the most prevalent symptom in this population as well. So treatment, there is no cure, unfortunately, and restricted intake of proteins, mainly phenylalanine and tyrosine amino acid is important. So for this aspect, we might have to get a clinical nutritionist input. Superdose of vitamin C in the dosage of 500 twice a day has been shown to be effective, but not completely. We have started our patient on this medication. However, so there's this specific medication, nitisinone, which is not available in Sri Lanka, said to diminish the production of and urinary excretion of homogenesic acid. Monitoring. So the patient should be monitored with ECG, echo, because of the arrhythmias and calcification of cardiac valves it can give rise to, and the calcification of coronary arteries also can be happen. Of course, the rheumatology and orthopedics for the musculoskeletal issues, and eye and ENT input as well needed. So after we found this patient, we found another similar patient, but they were not related and they were not in the close proximity as well. So if we can get grants, because in Ampara area, there's a lot of consanguineous marriages happening. So we intend to study more if we have the facilities to screen and to see what is going on. These are my references, and I would like to thank following consultants and medical officers and other team and my patients and family. Thank you.
Any questions from the audience?
Not that I know of. When I searched the literature, there's no published case reports. But then, because the nutrition input was needed, so when I discussed with the senior registrar in clinical nutrition, she has come up with one child when she was doing appointment in Lady Ridgeway Hospital.
I hope you have seen a lot thinking that your process is a marginal
Exactly. Yes, and we are not doing X-rays for all the back pains, so that's hence the silent culprit.
Ampara has no beach, but we have put the beach.
It's closer to base.
But some of these related diseases, if you go by the data from infection data, how many cases per million should be there, we should have more people, but they have also this down very price if we don't see some of these patients. Perhaps we have to check with colleagues from HDP like Pridesha was doing a lot of things in the clinical pathologists, they might have seen more. Any other questions?
We mentioned some drug for litisinol or something. How much or found out?
I have asked all the pharmacology colleagues and pharmacists. It is not in Sri Lanka. Other countries they have.
So, in the absence of any further questions, let me wind up and thank in our usual way.